Welcome, ladies and gentlemen. Thank you for joining with us for today's webinar. My name is Tisal Fernando, and it is an absolute pleasure to be your host for this session. As we embark on a journey of acquiring knowledge, tonight's agenda promises a captivating look at the global perspectives on optimizing healthcare workforce planning, addressing global challenges, and sharing innovative solutions. As an international hub for healthcare education and the premier healthcare training institution in South Asia, IIHS has recognized the importance of redesigning healthcare education programs to meet the evolving demands in the industry. Featuring Ms. Glenda Whiting, a registered nurse, registered midwife, and health educator and head of School of Nursing at IIHS, Mr. Paul Morris, Director of Nursing, James Paget University Hospitals NHS UK, and Dr. Kitsiri Edrisinghe, CEO, co-founder, Director Academic Strategy and International Affairs at IIHS. Let's confront the challenges head-on and seek innovative challenges on a global perspective. Without further ado, we will turn the timer over to Ms. Glenda Whiting, a registered nurse, registered midwife, and health educator, and also the head of School of Nursing at IIHS, to share her ideas on the current realities and future perspectives of the Australian health system workforce. Over to you, Ms. Whiting.
Thank you very much. I'm just sharing my screen. Hopefully that is coming up that everybody can see.
Yes, Ms. Whiting, we can see.
Thank you. And my video. Good evening, everybody. I'm sitting in Australia. It's 22:40 in the evening, and I'm in far north Queensland actually. So it's the wet season up here. So there's lots of storms and things. So I'm hoping, unlike last night where the power went off completely at 10 p.m. So far, so good. So let me hope I can get through my presentation. So lovely to join you. My topic, as you can see, is really talking about the Australian perspective. And to start with, I just wanted to show you some of statistics around Australia, the country, the numbers and those kind of things. So just initially worth noting that 2022 census showed that our population was almost 26 million, 25 million, which in the scheme of things with most countries and considering the size of our country is not that many people, I suppose. So in Australia, we have an organisation called the Australian Institute of Health and Welfare, and I have provided all of the web addresses for any of this information. So if anybody wants to look anything up after the presentation or in the future, they'll be there for you. But it's an Australian government agency that collects a lot of data around obviously health and welfare. And it also means that it's there available for us in generally a nice way, an easy way that you can actually access and get the information that you're looking for and do searches on. So that's where I've gained some of this information from here. And the other part of the information is from the Australian Health Practitioners Workforce as well. So that's the registration body, certainly for nurses and midwives. But there's a list of all of the registered Australian health workforce that falls under that statutory authority. The paramedicine practitioners, so paramedics, was only part of the register or became a registered profession from 2019. So that's a fairly recent one. But as you can see, it covers the generalists that you would expect there to be with physios and pharmacists and podiatrists. There's a large group of dental therapists as well as dentists, medical practitioners, nurses and midwives as separate registers as well today. But also some of the things that I guess won't appear in other countries like the Aboriginal and Torres Strait Islander health practitioners and Chinese medical practitioners as well fall into that category as well. So the Australian workforce, as it shows you there, is quite large and diverse, and there's obviously many different professional groups. But remember that the data here is only really showing us those that are in registered professions. So there's certainly others that work outside of that as well. And that falls under a national law and it's monitored, and obviously each of the professions then have to register with those. So I've drawn this data from that Australian Health Practitioner Regulation Agency. And really just to show you the number of practitioners, the latest data has come from 2020, but just the differences in that percentage of change from 2015 to 2020 and that percentage of change. And I think it's worth remembering that while the numbers certainly can grow, I'd prefer to consider looking at it as that stands for full-time equivalent per percentage of the population, because you might have more and more practitioners are coming on board, but certainly in some countries, if the population's also growing, you might not ever be kind of quite keeping up with what you need there. So as you can see, there was more than 642 health practitioners working within those regulated and registered professions, 105,300 medical practitioners, 350,000 nurses, 21 nurses and midwives. And I guess that's probably similar in most countries where the nurses and midwives tend to take up the largest group of registered practitioners. But certainly there was a large number that also worked around that allied health area as well. Relative to the population, the allied health workers really showed the greatest full-time equivalent rate growth from 2015 to 2020. But remember that the paramedic practitioners fall into that allied health grouping as well. So that was a whole new group of people that joined to contribute to those numbers as well. So that's contributed to increase across all of those populations as well. So the next diagram that I just want to show is a little bit more difficult. Hopefully you can see it quite well. In that I again chose, and this is again something from the Bureau that you can get where you can actually filter it in many ways, as you can see, but I filtered it here under that number of full-time equivalents per 100,000. I did it across all the states and territories, so that's all of Australia, and all professions. So it's just showing you in the colours here of each state, but generally just if you look at that, you can see there is that gradual growth. But then, of course, it looks like it may be kind of plateauing when we're looking at the number of practitioners to the number of people that are against the population. So it could be flattening. Obviously, you know, all of that data collection when we register, when we do census, when we do any of those kind of things is helpful for the governments, hopefully, to spend the money in the places that it's need to be spent in making sure that the health workforce keeps up. But there are things, as it says here, that, you know, there's a number of people that are employed in the health sector, or say that they're employed as a health sector worker, that are not covered by any of these groups. So they're not necessarily registered or regulated in any way. And while that includes things like allied ancillary staff, so clerical workers, hospital workers, cleaners, service workers, all of those kind of things, it also includes some what I would call professions like dietitians, health information managers, welfare practitioners, social workers, for example, that don't fall under that body. So they're not necessarily counted in there, but certainly dietitians, audiologists, speech pathologists are self-regulated by their profession. So I'm not inferring that they're any lesser than the professions that are on the other registers. So it's done to make sure that that safety and quality is certainly maintained by them as well. It just means that they're not necessarily captured in that government data sometimes, depending on what they're looking at, I suppose. So it could be that we're not really quite capturing what we need to with that. I think in talking in today's world, we can't really move on too far from the impact of the COVID-19 pandemic on the health workforce. And certainly working in education, where I was working, we certainly saw an increase in people that were interested in joining the health workforce, because at the time they were the people workforce that you saw on the television every night doing the swabbing, still working in the hospitals, still visiting, still looking after people in aged care. So it certainly boosted that idea of people wanting to perhaps join those professions as well. But it certainly increased the workload, affected the mental health of some of the people that were working. I think of all of us that were working in the health sector at the time. The workload certainly increased. There were issues about getting enough staff. We certainly had people who were actually contracting COVID. So all of the data showed us that the health workforce were 2.7 times more likely than the community to be infected. Purely, I guess, one, we were out and about. Secondly, we were dealing with people coming in with COVID, I suppose, whether it was diagnosed or not. And what happened in Australia was that there was some money that was put into fast tracking some of the people coming through the registration process. Any of you that have recently or completed your studies and then registered, it's a process to get there. It's even more of a process if you're coming from another country to get through that registration. So they managed to sort of create what they called sub-registers where people could get fast-tracked in. Like lots of other countries, Australia is attractive for people to come and live and work in, whether it's tourists or backpackers, as we say, coming in, taking up the everyday kind of jobs, but certainly nurses and doctors and dentists and those sort of people as well. So it was much more difficult to get into the country during COVID times. Australia was very strict about flights and people not entering, so it made a big difference. And it also, one of the bonuses I think that happened was that the government actually created an item number, so it was a paid number through the Medicare service, the benefit scheme, that MBS scheme for telehealth. Previously, telehealth was kind of limited to people who lived in remote and rural areas that could physically get to a doctor, but it became a lot more commonplace. And I'm happy to say that that item number continued, so it's still happening that you don't physically have to go to the doctor. The other thing that happened that caused some issues was around elective surgery. So like most countries in that modern days, the waiting time to have an elective surgery done through the government public system is slow, and certain procedures are, in the years to have something done. And certainly because of that elective cause meant that those surgeries were then put off during COVID times because, again, the staffing was an issue. They wanted to keep beds available in case we had large numbers of people coming into the hospital. So that created a bit of a backlog from that as well. The Nursing and Midwifery Board certainly were allowed people who had recently left the profession, recently retired, if they wished to go back onto the register so that they could be called into work if they were willing and needed to, if we needed to have larger numbers during that time. Fortunately, that didn't really occur. So it seemed to work out all right. But I just want you to keep in the back of your mind that some of those things that happened during COVID were good, as I said, the telehealth, but there were other parts of it that I think there's still a bit of a delay in those things catching up to get back to normal numbers as well. So if we move to thinking about what's happening in the future and what will happen, like everything, health is in a significant transformation. The workforce is the biggest growing workforce in Australia. And of course, and honestly, I have to say, probably since I've been a nurse, which is a really long time, we've been forecasting workforce shortages. We certainly have an ageing workforce, and there are certainly challenges around retention. Some of that, as I said, is part of the COVID hangover part, where people who were perhaps almost retiring or thinking about another 5 years or 10 years really decided that was enough, that was it, and they've left the workforce since then. And that whole concept of retention is something that really has to be considered as well. The generations of people that are coming through the workforce compared to myself, where a large number of people of my generation got a job, stayed in that job, or trained in that job, as in being a nurse, and stayed in that job for all of their life. I've certainly been a nurse all of my working life. I've gone off in different directions, but I still would certainly identify as being a nurse, not necessarily with the same employer, but certainly the generations coming through are changing jobs a number of times throughout their working career and changing industries, not just that job. Obviously, the digitalisation of everything, and certainly, again, COVID pushed that along a bit further. You know, just think about who carries money anymore. Everything's done online a lot more. So the skills of people that are working within the workforce need to be changed to deal with that as well. And certainly that's no different in healthcare. There's certainly an increasing and changing demand for the services that we provide. And if I think about the time that I've been in nursing, when people would come to hospital, have an operation, they'd come in the day before the operation, sometimes 2 days before. We'd prepare them for the operation. They'd have the operation. They might stay for a week. It could be even longer, depending on what it was. We had nothing like day surgery in those days. That was something I've never heard of. So there's been a lot of those changes happen in that 40 years that I've been in the healthcare system. But certainly the demand and the changing landscape, I suppose, has certainly changed. And certainly there's that community and government expectations as well. So we all know that whatever country that you live in, whatever government that's managing that country has a limited amount of money to spend, and how they spend it is obviously very important to us in healthcare, that we have the right facilities, we have enough staff, and people can access that healthcare. So that community expectation is certainly changing as well. There needs to be an investment in the infrastructure, so the buildings, the equipment, and all of those kind of things to keep up. We're certainly working, and in the future we'll continue to work much more with the multidisciplinary teams, so that there's that seamless transition from the primary care to perhaps hospital care to aftercare to home care, whatever that might look like. And that technology and that AI stuff that's coming in is certainly something that can assist with that. So if, for example, all the information is stored online in that sort of world, then it can be shared much more easily with people. I guess in Australia, one of the ways that that can really kind of fall down is that if you're not within the same organisation, people won't share the information with you. So that can be a bit of an issue. But all of those things that I think are happening certainly a lot faster in other industries are starting to get pushed a bit more, I suppose, with healthcare. So the group of things that I just wanted to finish off by just sort of putting out there for everyone to consider is that we've always talked about this human-centred model of care. There's certainly an increase in complex care. People are living a lot longer, and obviously the longer you live, the more likely you are to have comorbidities or other things that need to be cared about. We need to have a coordination between those practitioners, and almost that equality of practitioners where nobody's more important than anybody else. Certainly in different parts of the journey, they may be more important, but that everybody is working together. Chronic diseases, as I said, is becoming an issue, and a lot of those things don't need to be cared for or managed within a hospital setting. They can be managed through primary care or community care as well. And certainly that collaborative care with the patient at the centre. I think those of us that work in healthcare easily recognise that if the patient is part of the care, understands the care, not just saying the patient, but their family and anyone that's around them, they're much more likely to contribute to that and move forward with that as well. We talked about, I mentioned before, about the digitisation and technological transformation. So there's lots of automation, there's robotics, and there's AI that's coming more and more that improves the patient's experiences. It increases the productivity, that there's somebody else doing the tasks that free us up to do the patient care kind of things. The laboratories, you think about if you've been in a pathology laboratory, how automated the equipment and the machinery is there. Certainly decreases the incidence of inaccuracy, and diagnosis is much more quickly processed, therefore treatment can start more quickly. But to manage that, we all have to know how to maintain or learn those digital IQ skills of workers, that we all need to know how to access the information, how to digest the information, pass the information on, all of those kind of things. And as I said, that other part about keeping people out of hospital and certainly keeping well people out of hospital, and just trying to kind of maintain, I suppose, that concept that, hospital shouldn't be just about sick people, but it certainly should be about that throughput, I guess, a bit more about that. I think the other thing that is worth just considering as well is that for those of us working in education, part of the process for us is that we need to make sure that the education that we provide and the training that we provide, and certainly the experiences for the students in their clinical components, have to match what's really happening in the world and the future, because we are creating, whether it's a brand new person coming into the health system or someone coming to upskill or change skills or change jobs, we're actually preparing them for today and for the future workforce as well. So we have to keep our eye on what's happening out there and what we can do to make sure that they are getting all those digital skills as well, that they can understand that technology, that they can get a broader output than just their own profession as well. And certainly, and I know we do this at IHS as well, I did a session last week with students in the room that were from the nursing, from physiotherapy, and also from biomedical science. And it's lovely to see that mix of people. And I think that any institution that has a cross and throughput of different professions can certainly help to build that collegialness, I suppose, so that when they get out there to the workforce, they already know a little bit about those people, and they can share that information and what everybody else does and works. Okay, so that's all the references that I have for you there. As I said, I'm sure that this will be available to you. I generally have them, they usually ask for me to send it in. So I will leave it there and allow the next person to have their say. Thank you very much for listening.
Thank you, Ms. Whiting. Ladies and gentlemen, a kind reminder, if you have any questions, please hold on to them a little while, and you can share them during the Q&A session or drop them in the chat box. Well, with that, we are moving on to the next presenter, Mr. Paul Morris, Director of Nursing, James Paget University Hospitals, NHS UK, to speak on optimizing workforce planning in the UK healthcare system and challenges. Over to you, Mr. Morris.
Brilliant, thank you. And I will just share my screen if you can just confirm that you can see my presentation. Fantastic, thank you. And sorry about that. My name is Paul Morris, and I am the Chief Nurse at the James Paget Hospital, RU Bowen, I should start with. And thank you very much for welcoming me to present. I'm here to talk about optimising workforce planning in the UK healthcare system and some of the challenges. I will be focusing on nursing in particular, and have been using the developing safeguards and workforce guidance from the NHS, and also the Selford Group model of Safer Care nursing tool. Safer staffing for nursing and midwifery is very much based on an evidence-based approach around decision-making, ensuring that we make safe, effective staffing requirements, both for the here and now, day by day, but also for planning for the future, both in for retention of staff, growth and development, and also for future needs of services and our patients. Dame Ruth May, who's the UK Chief Nurse, was very much committed to increase the number of nurses within the NHS by 40,000, because very much the requirements of the NHS exceeded the supply of nurses. So in order to do that, we needed to review how we go about workforce planning, how we delegate those tasks, growth and development in non-registered professionals, but also we know that it's a particularly challenging time because this brings significant opportunities, but challenges around demand, training, cost of training, and cost of delivery of healthcare.
Excuse me, Mr. Morris.
Yes.
Can you see there's an option called display settings at the top of your screen?
Yes. Do you want me to? Here we go. Is that better?
Yes. Thank you so
Yep,
much,
there we
Mr.
go.
Morris.
So the principles of safe staffing really form very much three key components that surround safe staffing as a topic. And these are using evidence-based tools such as we use the Safer Care Nursing tool developed by the Shelford Group. That then incorporates monitoring and measuring your outcomes. So not only is it about ensuring that the correct staff are planned for, developed, and employed and recruited into, but what impact, what are the outputs of that staff group and how can they be measured? Does it improve outcome? Is it the numbers, or is it around the seniority? Is it around the productivity? And then incorporating that then ensures the last piece of the triangle, which is professional judgment, because it may be that you know a certain area will need more staff because it has a junior skill mix, and therefore that's a temporary resource that needs to be added to ensure that there is safe delivery of care. Establishment setting in the NHS should be done twice a year. One is a full staffing review and one is an update on that staffing review, which requires us to monitor and review individual patients, their acuity, their care demands using an evidence-based tool. This tool will look at your activity levels, how many beds you have, how sick your patients are. Is there any variation, whether that is seasonal variation, days of the week variation? And this can enable you to proactively address any gaps or predicted gaps in workforce management. It also allows you to predict if there's going to be any changes to your contracts, seasonal variation. If we know that a large number of staff won't be required, so what impact does that have on planning for your staffing resource to be moved elsewhere, such as holidays? If a part of a service doesn't work on the holiday period, but the nurses do, where can they be redeployed? Also, the ability to look at your temporary staffing and junior skill mixes and enable those reviews to enable review of your establishment, whether that's temporary or permanent, or a redeployment of your staff. So the aims of a workforce plan is very much around the robust planning, having a very structured approach so that you can predict both in the future and imminently by day. And we'll talk about that very briefly next. It's important that we use evidence-based. So is it a ratio-based, a percentage-based, evidence-based tools using acuity? And by using this enables you to predict, but also enables you to evaluate your resources and then predict the staffing requirements for that resource. And I'll explain this in greater detail shortly. But what this goes on by being proactive and having effective management of your staffing means that you use less agency, which is high cost. You need to ensure it links to your clinical strategy so that you build your workforce not just today, but for tomorrow and the years beyond. It is vitally important that both nursing, midwifery, our operations colleagues work closely together to ensure collaboration and maximum efficiency and productivity. Any changes need to include a quality impact assessment in addition to any risk assessment to ensure that the impact on quality has been developed and mitigated. So with the Safer Care Nursing tool we review every patient over the course of a month, every day. This enables us to establish the requirement of care that they require. So 0 would be that they are a patient who requires hospitalisation, but their needs are met by the normal resources of the ward. We then have a 1A, which is unwell patient who requires intervention and is unstable or at the risk of deterioration. 1B is a patient who is stable but requiring nursing care to meet all of their needs. And then level 2 is a designated bed with specialist staff, such as a level 2 unit or a high dependency unit. A level 3 is a patient requiring advanced support. An intensive care patient would be a good example. So using this data, we're able to put this into an evidence-based decision-making tool. And what this does is this gives us the levels by day. And what we can see here is a generic ward, which has around about 40 beds. We know that it is recommending that there is a high proportion of level 1Bs and 1Cs. So there are patients who need to be in hospital, but they might deteriorate and they need quite a lot of nursing care. Now, the second part of this graph shows the full-time equivalent and breakdown between registered nurses and healthcare assistants. So what we actually can see is that our unregistered staff and our registered staff breakdown is around about 50–55%. And what we need is we need to match that number. So on the next slide, what we can see is when we put this in, we work on a ratio of around about 2.6. So this means the ratio of conversion. So for every 12 hours of care, we need 2.6 registered nurses or healthcare assistants to provide that 7 days a week, 365, incorporating any training needs, annual leave, or sickness. By putting this all into the mechanism of the blended tool, it then enables us to tell about the whole time equivalence. And what you can see here is day by day, a ward, which we then take this information and how many registered nurses and healthcare assistants we would need to provide care in that environment. So you can see here, it is around about 5 combination of registered nurses and healthcare assistants to provide care in the appropriate setting at safe staffing. So we use this tool and we do this twice a year for all of our clinical areas. This enables us then to predict if there are any increases or decreases in establishments, redeploy nurses, healthcare assistants, or the money that supports those budgets to really ensure that we've got productivity and efficiency across the whole of our organisation. To do this and ensure safe staffing, we use 4 key approaches. These are regular staffing reviews. This includes a daily forward planning over the next few hours of the ward, but also about reviewing our leaver rates, ensuring that we maintain high standards of, ensuring that we enable us to predict that how many nurses will we need, which then allows us to recruit proactively, and also ensure that we can grow our own staff, develop our own staff from healthcare assistant to registered nurse, which is really, really important. And by monitoring our leaver rate, ours is currently around about 5%, which means that we predict around about 50 nurses this year will leave our organisation to move to other organisations, retirement, for various reasons. So then we work to recruit those proactively to minimise the use of agency and any gaps in our workforce. The other 2 elements are recruitment of registered staff, both from around the UK and our university, so newly qualified staff. And one of our biggest campaigns is about our international recruitment. And this is a process that we run, that we're able to recruit internationally educated staff. We are able to recruit them, interview them, put them through their OSCE training, and then embed them into our organisation so they work alongside all of our staff. So this is how we at the James Padgett, our approach to challenging ourselves with the challenges around workforce planning, but also recruitment, retention, and ensuring safe staffing. Happy to take any questions. Thank you.
Thank you, Mr. Morris. That was a very insightful presentation. And ladies and gentlemen, I would like to remind you again, if you have any questions, you can share them on the chat box, or else you can ask them while at the end of the presentations during the Q&A session. So with that, it is indeed an honor to invite Dr. Kitsiri Adrisinghe, CEO, co-founder, Director Academic Strategy and International Affairs at IIHS, to enlighten us on innovative approaches to training and skill development in healthcare workforce. Over to you, sir.
Good evening to everyone. I hope I'm audible.
Yes, sir, you're audible.
Okay. Thank you, Ms. Glenda Whiting and Mr. Paul Morris for those valuable comments. What I've tried to do now is to give you an insight to what are the methods that we can use in order to find solution in terms of training. Okay, I hope my slides are visible.
Yes, sir.
Yeah, I'll just give you an insight. We've heard about the situation in Australia and as well as the UK, as well as what the strategies they have adapted in terms of clinical environment. I will first just give you an insight to the problem in hand. So if you really look at the workforce crisis, it's global pandemic. You can call it a pandemic now because it's everyone says it's the workforce problems are current problems are so huge, and if you don't take proper action, future will be more difficult. So so if you really look at according to WHO estimates, nearly a couple of million, about 18 million health professionals are needed in the world, and USA needs about 1 million nurses by about 100,000 doctors and about 1 million nurses by 2030. Germany, another, they need loads of healthcare workers as well. India needs about 3.9 million healthcare workers. And China, after now they're about to remove their one-child policy. With that, they need about 180,000 obstetricians. So you can just imagine the amount of nurses that they need, at least into 6. So there, the world over, the healthcare professional crisis is escalating. And these are the basic common ones, reasons that why the healthcare force is in a kind of a crisis. So what I will only look at, other than the commonly known cases, I will look at the workforce shortages in my presentation. If you really look at the South Asian region, not much of a studies have been done, but I was lucky enough to do a presentation some time ago with Deakin University in Pakistan, analyzing this. If you really look at just look at this table, and if you just concentrate on Pakistan itself, there are currently about 74,000, probably now maybe 80,000 now, nurses are there. Just took nurses as an example. Their population is well over 200 million. So roughly they need about 1 million nurses now. And currently they have 163 nursing institute producing nurses, and they produce roughly around 8,000. If you divide 1 million by 8,000, they need 122 years to achieve the current need. Right? So you can think about the future needs are. So this is an area people have not really looked at. Health authorities, global organizations. It's pretty bad. So Sri Lanka, we have about now today we have about 45,000, and we are producing about 3,000 a year. So we will achieve without much of a problem. But still, there is a challenge. So therefore, you really need to look at a different paradigm. You have to shift our paradigm looking at training, shift our paradigm looking at healthcare, how healthcare workers would do, which we heard some about a couple of minutes ago. Definitely have to fix this in looking differently at this. But if you really look at the or everybody talks about leveraging technology, use of technology for day-to-day practice, and expand the education and training. That's the area that I'm going to talk about, and attract diverse talent, because it is not should be limited to certain cohort of people in the society. It should be open to everyone. So open out then, how can we do that? and policy and regulatory changes, because healthcare is very stubborn for innovation, always resist. It's a regulatory industry, but we do really have to relook at it and then improve the other public-private partnerships. How can you get community engagement? I know Australia does it very well because they would get the family members getting involved in some of the clinical procedures because the travel distance is so far. Of course, the public-private partnerships. I'll look into just giving you an insight to what is basically training is. Now, basically, we look at the experience, we give the knowledge, then we give the experience, and then attitude and desire and values, all those come in one basket. So now today's world, the knowledge is, it's a different ball game, inculcating knowledge. Skill levels, absolutely yes. So we really have to look at how to improve the skill level. And this interest levels or the attitude or the value set, that comes from the clinical environment. It really have to, we can do something on the academic environment, but it's all critical. So I'll give you a insight to one of the Harvard professors. His name is Eric Balinsky. He talks about education and how we use traditional methods. I've just tried to read a bit of what he said. 99% of teaching spaces were anticipated either in an image of an ancient Syrian palace school 4,000 years ago or a Greek amphitheater. I'll show you amphitheater in a while. Rows of rings of seats mean to focus attention of many to one. But education is not about transferring information to one to many. It is about learning within the student. When the printed books were new, transferring information are vital. But today, information is ubiquitous. That's readily available. The classroom, so students can pick up when and where they want. Instead of the classroom ought to focus on assimilation and application of knowledge in new context, the teacher becomes a guide on the side instead of sage on a stage, requiring wholly new learning spaces and teaching techniques. So these amphitheaters. We still, we design and build training centers like that. You get auditoriums, you get all these. It has to be changed. Time has come. So we came up with this concept. We just started a couple of years ago. Of course, the support of Coventry and of course the East of England, where Mr. Paul Morris is there. That just looking at this differently, we know there is a problem in everywhere. Roughly around 13 million, if you could, nurses as a case study. So we currently, what is happening is the first world would recruit nurses from the third world or the developing countries. So those are called low-hanging fruits. But there is a injury or there is a danger that those systems can collapse. Because we take them from there. But there is so therefore strategically there has to be, this justifies to look at this in a different paradigm. There's a short-term, medium-term and a long-term solution for this by supporting the third world, because we have enough hands, developing countries. So around Sri Lanka, we have about 250 million youth. In Africa, 350 million youth. You can train them. Versus the first world has limited hands. So therefore, we could, if we strategically look at training in a different perspective, how we share resources and do things together, then definitely we can find a solution. So we came up with this concept called practice ready, nurse fast. It looks odd in a way when you look at it, but I'll try to give you an insight to what it is. So we look at with a different paradigm. How can you look at this training in a different paradigm? Let's look at how the input to the training programs. We take nursing as a case study, but you can use this to other professionals as well. Input, process, output, and outcome. So let's look at the input. how can you accelerate the input? How can we get more people into nursing? Take nursing as an example. So nursing is a career in second world and many countries, not as a first choice, but a fallback plan. If they don't get X, Y, and Z, they would go into nursing. That is the traditional way of looking at nursing. And there are handful of people who really passionate, like Miss Glenda Whiting, coming to nursing to do nursing wholeheartedly. So therefore, there has to be a massive campaign creating at national level, which we are about to launch in Sri Lanka, called Hedda Nanaveduma, where we are going to get 10 to 15,000 youth to come into nursing in the next 5 years. Finding solution to that to improve the input. And then there is a massive stigma in nursing in this part of the world. And then misconceptions. And so therefore, there has to be a orientation program given to school kids and the others in order to remove the stigma and the value of nursing. And reducing barriers. There are enough barriers in healthcare. So there are academic barriers, because they would say you have to have advanced level 13-year or 12-year qualification, A levels, and then you have to come from science background. There's no evidence that says, no research, there are science students who do better than the art students. So there are a lot of things, age, gender. In this part of the world, only 5% of the males are allowed to come to nursing. So we have to improve the inclusivity, allow people to come in different levels, certificate, diploma, degree. We should allow now. Recently, America, US, one university started 1-year nursing program. So there are different entry for bachelors, so they can come and do a 1-year nursing program. Geographical accessibility. How can you allow international or high quality program to being accessible to a country like Sri Lanka and the South Asian region? So that's what we do with Coventry University. And economic accessibility. These healthcare programs are extremely expensive. And even in UK, in the first world, Australia, it's extremely expensive to do a nursing program. So now how can you make it affordable? How can government subsidize this? So that's very important to look at. And increase the capacity. Now we have enough capacity in most of the universities, but we have traditionally we work from say 8 to 4 or 9 to 4 or 9 to 5. But why can't we have a 7 to 11? You know, if the consumer outlets are doing 7 to 11, we can do 7 to 11. There's enough capacity. It's a matter of getting resources in. If you look at the academic part of it, so how can you create a positive, conducive environment and a culture? Because it's currently, especially in the developing countries, it's a very stubborn culture that created this. Kids are not like to come and learn healthcare programs because it's very difficult to study. So how can you sustain students within a program? Creating student-driven, they will part of an enjoyable environment and improve flexibility for them. How can older person can come into nursing or other healthcare programs? Age cannot be a barrier, should not be a barrier. Activity-based, collaborative, evidence-based, reflective, critical thinking student, and technologically driven people, because technology will come whether we like it or not. We'll have to change in the years to come. Reduction of the physical engagement by using technology. Because you need not to have physical engagement all the time. That increases the capacity. And there's academic shock in healthcare training programs. As you come, it's always you see sickness. You always see sadness. There's a shock, academic as well as a clinical shock. How can you remove these barriers? Can you do accelerated program? Because as I told you before, do you really want to study 3 years nursing or 4 years? Do you really have to do 5 years medicine? Because when we were medical students, we study cardiovascular system for about almost 2 months. Now you can do that in a day. But technology has allowed us to do that. So what do we need? But we need academic program can be shortened and they can be a 1 year internship. So it's still a 3-year program. These are the things that we can look at and change ourselves. Medicine can be 3+2, 3 years and 2 years of internship. And do bare minimum essentials. I know still in Sri Lanka, I've seen nursing students are continuously do bed making for over and over again, as a part of their routine. Can we concentrate on essential of learning? And can you do CPDs, specializations, using online programs and learning management systems? Training nursing educators is one of the very important elements, because we still, when you come to Sri Lanka, you would see, first thing what you see is a Miss Nightingale's statue. It's a good thing to do, but they would pray here like a god. But things have changed. We still, we had to come to science, because Miss Nightingale created a science. It was a caring thing to science. So it's, training educators as well as looking as, like Ms. Glenda said, collaborative learning with multidisciplinary groups, including medical and nursing. If you look at as a case study, as we were using learner management system for well over 10 years. And we started as a VLE platform, and we run around roughly around 5 learner management platforms now, and there are 350 plugins. 0 paper consumption. We save a lot of cost by using learner management systems. We have online exams, advanced security options. Student can monitor their progress on their own. Many facilities. So it is a total success. We are a really good case study in South Asia. We have won many awards for this from Commonwealth Digital Forum. If you look at the clinical area, so how can you expand the clinical base? Now, one of the problems that these healthcare programs would look at is we don't have enough clinical placements. There's a cap in clinical placement. To do that, I mean, there are repetition of some of the procedures continuously. Can you restrict some of the, once you learn, that's it. You do one procedure with one patient, right? And then once you get the competence, that's it. And then how can you use technology to minimize physical engagement, simulations, and elimination barrier on nursing caps, as I told you, clinical caps. We could really look at simulation centers and using XR and VR technology, video-based education. And you can look at, there's enough clinical placement of this part of the world, like Sri Lanka and South Asia. First world can look at developing countries. How can we fast track training? There's augmented reflective practices rather than doing the logbooks, traditional logbooks. So reflective practice will not only give the candidate just doing a procedure, but he come up with a critical thinking base. Important to, can we look at improve the attitude towards AR and VR technology and learner management systems? Current educators are looking at them with a different eye. So we have to improve the effectiveness and advocate towards them. I spoke to you regarding that. Targeted clinical training, objective based training, do the essentials. The public-private partnership. Now, private sector has enormous amount of facilities, like IIHS has one of the best simulation facilities, as well as the demonstration facilities. As well as the government has enough clinical practice facilities, placements. Can we work together? If you look at the case study, we have a XR nursing hub, one of few in South Asia. started with Bundle of Brains by Brad Chisholm of Australia. We use headsets, and there are enormous amount of facilities available. It could be a global classroom where many countries can to be together. We can do about 70% of our procedures through this, and 45% of cost reduction in nursing. And then these are some of the pictures that they use it. And we had the prize catch with the US ambassador who just visited recently. She also experienced the XR hub, Her Excellency Julie Chang. Then also we created the high fidelity simulation center with the support of Coventry University. They have already donated few high fidelity mannequins. And there's enormous amount of work that we can do with this. And we are training staff, task-based training, using virtual reality is another area, and do a lot of applied research on this. So a lot of advantages on this. With a control room, you can do simulate different clinical environments. It's an amazing tool. Co-curricular activities, research, reflective practice, community engagements, problem solving, critical thinking practices are very essential for today's up and coming healthcare professionals. Also, creating a global mindset of healthcare professionals is important because COVID kind of a disease can initially spread and people can migrate to different countries. And divergent thinking. Thinking has to be having more answers to a question, and then improving a leadership and the team building, because we have to work as a team leader, as a team member of a healthcare professional team. How to reduce stress and performance through technology. We have to do that during the student time, how to manage stress, how to do accuracy and precision of the work, and how to improve productivity, which Mr. Paul or Boris just mentioned a while ago. And how can we reduce the burden of let's say, a doctor with a physician associate, or nurse, RN with a associate nurse, or enrolled nurse, or healthcare assistants. So minimizing the workload. And can we use technology to reduce their workload, the wearables and etc., telemedicine, hospital information systems. Creating a global universities, that's what Coventry University is currently doing, creating a global universities, creating people to move around, using best practices, absorbing best practices. And one of the barriers for developing countries to move into developed countries is the English competency. We had to question, is 7 IELTS or equivalent, is it really necessary, or can we lower it? And then there is a problem in hand. A different global system orientation to others, and pre-registration programs if they're going to go out of the country, and direct placement from training organizations. That's what we are doing with East of England and as well as the James Paget Hospital, and then allocating funds for training. These are some of the things that we can do. And I will also wait for any questions. I have few references as well. Thank you.
Thank you, sir. Well, with that, we are moving to answer some of your valuable questions. I would like to invite the audience members to raise your questions to Ms. Glenda Whiting, Mr. Paul Morris, Dr. Kitsri Edirisinghe, or drop your questions in the chat box. We have received one question to all the three panelists. Whoever it is can answer the question. So the question is, the impact of technological advances such as big data and AI on the enrollment of HCPs in the years to come, considering the pay gaps among other professionals. Value your thoughts to all speakers. Shall I repeat the question? So, impact of technological advances such as big data and AI on the enrollment of HCPs in the years to come, considering the pay gaps among other professionals. Any thoughts to be added to that question?
In terms of training, of course, AI, we are currently working on this. There's a lot of debate on loads of kids are using, students are using AI. So there is a very negative approach by many professionals towards this. We, as an innovative organization, we look at this as a positive entity, because as I told you before, knowledge is very ubiquitous because it's freely available to everyone. So inculcating knowledge, we could use technology very easily, and AI control way of doing it. Currently, we are doing a case study on this using AI in academic environment. Clinical environment, you have to look at positively, because that's definitely it will come. Healthcare will have to change. Training, of course, we have to use it very carefully, but we should allow them to do in control environments in terms of training.
Thank you. And I suppose my viewpoints would be particularly around technological advancements and AI. We start to use AI in the clinical environment. So, for example, the interpretation of ECGs or X-rays, so that actually they can use the intelligence to analyze and look for abnormalities. We're co-running that with the clinicians, and it's been really interesting to see the results of both clinical reviews, time taken, and AI clinical reviews and time taken, and the outputs. So I think if used, building on Dr. Kassiri as around his comments there, is used wisely, it can really make a big difference. And the vital importance of big data and the ability for sharing that data, and then really emphasis is especially around, as we look at challenges in workforce, you can then use that for predictive values moving forward for planning for 1, 2, 5, 10 years time. So it's really important, I think, is using the data.
And if I can just add further to that, I agree with both of the other comments. I'm just not sure with your question whether you're asking would people consider working in a profession other than health? Is it about the fact that, I guess, perhaps the general population doesn't realise the amount of technology that we use in healthcare, and perhaps not aware that it is not really a hands-on based occupation completely. There's lots of things that are going on, as Paul mentioned, with X-ray facilities, reading results, interpreting results. Like I said, the laboratories being very automated, those kind of things that I'm just not sure when I read the question as to what was the way that was trying to head. So that would be the other thing that certainly I think that part of the promotion that we do in encouraging people to come into healthcare would also be letting them know that it's about technology as well, and the skills that they may already have from their everyday life could certainly be used in their healthcare. And they, as Dr. Kassiri said as well, about the study that they do is using technology and doing that as well. So I hope that covered that question.
Thank you, Ms. Linda Whiting. Thank you, Mr. Paul, and thank you, sir. So there's another question to Dr. Kitsiri Edrisinghe. The question is, what challenges would need to be anticipated considering the Asian cultural backsetting if we are to achieve this concept of reducing physical engagement of clinical programs and breaking the traditional learning styles among peers in both the state and private sectors?
It's a good question, a very, very, very timely question. Because if you really look at take medical education, it's the highest on the ladder in terms of Asian countries. If you really look at the top end universities like Aberdeen, Dundee, they all are, their whole concept is not like the Asian clinical setting. Asian clinical competency is equals to how many people, how many patients you saw. That's the clinical setting that we have. We are changing a bit, but still we are about, I think, 20 to 30 years behind the first world, or England, or Australia, or USA. We look at, because we have patients who can be used as, guinea pigs. They don't complain. They would tolerate this. But if you really look at the first world or developed countries, they do complain. They will not allow you to poke these needles around you many times. So that's what the technology is needed. So you simulate before you see the actual patient. Current concept in the first world is you see a patient and do a procedure. So I know Sri Lanka is also loads of dialogue going on. You see many patients, and is that mean you see many patients and hurt them? Or to get your competence? No. You see only a patient and do a procedure. I mean, maybe one or two. So you have many things to do before. You have simulation, you have different technologies. You can use a patient actor before you go to a real patient. So the clinical hours spending there, you can spend, it's not about the hours you spend, the days that you spend. The competency would come, you can get it from your patient. It's the clinical acumen that you get, thinking, critical thinking, and the experience. That could be, you can spend time there. It's not the number of patients that you see. So therefore, this mindset, different paradigm, or the paradigm shift has to come in to our part of the world, totally Asian culture. So we have to change that. And the patients do change. Now they know about their rights. They read a lot. They are knowledgeable. Health information is not at all asymmetrical now. It's getting symmetrical. So therefore, it's time to change. That has to happen no quick time. That's my opinion. Linda, any thoughts?
No, I would agree, but I think as well, my experience of being in Sri Lanka is that it's not just about the educational setting at a university level, it's about the educational setting throughout schooling as well. And I think if you compared that to how we educate in Australia or the UK and other first world countries, children don't just sit in classrooms and listen to the teacher. There's lots and lots of research about how people learn and how it's better to incorporate different activities with all of that learning as well. So that whole process of going to school at this time in the morning and finishing at this time of day, all of that. And the only other thing I would probably add for the tertiary level education is that it's not just about not spending as much time in learning, but it's about not actually spending time listening, and that the learning is perhaps practical learning and doing things. Like I said before, we refer to it as flipped learning, where you at home learn the theory, the process, and then you come in and practice it, whether, as Dr. Kitsiri said, that's with an actor patient or with another student that you practice interviewing. It's, or talking to you, learning all those other skills as well. It's not just sitting in the room listening to somebody talk at you like most of us experienced at school. That's that difference in doing that. So I guess trying to focus on we're not having people come and learn as much, be on campus as much. It's about what they're doing when they're there that makes that difference.
Thank you for your thoughts, Dr. Kitsiri Adrisinghe and Ms. Belinda Whiting. Mr. Paul Morris, do you have anything to add for that? Okay, thank you. Thank you so much, Mr. Paul. And while we are appreciating the three panelists, ladies and gentlemen, it is time for us to conclude the proceedings for this webinar. And thank you everyone for joining us, and we appreciate your participation. And we hope you gain knowledge on workforce management in healthcare while addressing challenges and navigating the future. It was an amazing session, and I wish you a very good night. Thank you, everyone.